Thank you, Roger, for your introduction, and good afternoon, everyone. First of all, I'd like to thank Professor Yehuda Schoenfeld for his kind invitation to share with you our view about personalized medicine. I don't have any conflict of interest to declare, and the overview of my talk is shown in the screen. I will tell you about what personalized medicine is, or at least our view about personalized medicine. Remind you what is a biomarker, and in particular, what is a good biomarker. Tell a little bit about the scientific opportunities of personalized medicine, and at the end, I like to show you an example of personalized medicine related with rheumatoid arthritis. Personalized or precision medicine, the terminology is evolving. Personalized medicine at the beginning was considered as the use of information from a patient's genotype to initiate a preventative measure against the development of a disease or condition, or select the most appropriate therapy for a disease or condition that is particularly suited to that patient. At the beginning, personalized medicine only took into account the genetic profile of the individual, but then precision medicine comes with the involvement of not only the genetic part, but also of the environment. In autoimmunity, personalized medicine remains a research concept. In fact, it is not yet ready for the clinical practice. And from a clinical point of view, personalized medicine is to practice medicine as it was used to be in the past, but using the current biotechnological tools. In fact, as you know, there is no diseases, but rather patients. And personalized medicine, as I said, is not genetic medicine. It's more than that. In fact, we not only have the genetic profile of our patient, but also what happens thereafter, including transcriptomics, proteomics, and metabolomics. All the omics techniques, together with database and repositories such as ENCODE and others, new mathematical approaches and bioinformatic tools will help to decipher the complex ways by which genetics, epigenetics, and ancestry influence autoimmune conditions. Let me remind you that we're talking about complex diseases. That means the interaction between several heritable factors with several environmental factors over the time. Concerning the genetic predisposition of autoimmune diseases, as you can see, the influence of genetics on autoimmune diseases is not the same for all the conditions. For instance, based on concordance and aggregation, you can see that the influence of genetics on these diseases varies from type 1 diabetes mellitus, in which the genetic component is very important, to rheumatoid arthritis, in which the genetic component is not as important as it is in type 1 diabetes mellitus or multiple sclerosis. Another point that I want to highlight is the term of heritability, which is the ratio of variance by expressing the proportion of the phenotypic variance that can be attributed to the variance of genotypic values. In other words, the effect of the genotype on the phenotype. Therefore, genetic factors of diseases should be examined at the population level, and this is very important for our view of personalized medicine. The other part of complex diseases such as autoimmune condition is the environment, which we have called the autoimmune ecology. There are several environmental factors incriminated into the susceptibility or prevention of autoimmune conditions. And this autoimmune ecology is similar to what has been called the exposome, meaning all the exposures, internal and external, across the lifespan, interacting with hereditary factors to favor or protect against autoimmunity and its outcomes. And as you can see, there are several environmental factors, including physical and chemical agents, infections, of course, lifestyle, social factors, and even psychological factors. So instead of being the genetic medicine, personalized medicine could be the biomarkers medicine. Biomarkers are biological measures of a biological state that are associated with a particular disease state. Its analysis can help to predict risk and outcome of a disease, as well as classify subphenotypes and subgroups of patients who have the same molecular variation of the disease. And there are several outstanding presentations which will follow mine, and probably all this presentation, which includes the use of biomarkers in autoimmunity, will follow the checklist for our biomarkers to be useful in clinical practice. The first characteristics for good biomarkers is to have a good specificity. The second is to be safe to measure, easy to measure, and be at low cost for the beginning as well as for the follow of the individual or the patient. Fifth, has a greater value than the classical biomarkers used in clinical practice. For instance, if we will have a good biomarker for lupus, this biomarker should be better than anti-SM antibody, for instance. Have a good performance characteristics, that means have a good sensibility, specificity, negative predictive value, positive predictive value, and likelihood. Also, a good biomarker has to have a good correlation with disease activity score, shows modification between early and late disease, and last, be consistent across genders and ethnic groups, except when these good biomarkers is a genetic factor specific for a particular population. Even though there are some concerns about personalized medicine, including the commercialization and the lack of regulation, there are a consensus about when to perform or to ask for a new biomarker. The first one is when we want to diagnose or identify a risk for a particular disease. The second is when we want to improve the disease classification. And probably the most important is when we want to obtain or decide an intervention for that particular individual or patient. A humanized approach to personalized medicine offers the possibility of exploiting system biology and its concept of P5 medicine, which was first proposed by Leroy Hood as P4 medicine, but we include the fifth P, meaning population, where factors that are predictive of developing a disease should be examined at the population level in order to establish preventive measures in at-risk individuals for whom healthcare should be personalized and participatory. This is the steps on the road to personalized medicine. After having an informed concept, we get biological and clinical data, which goes to a biobank and a data repository. After having done all the experiments or looking for particular biomarkers, we perform a complete data and bioinformatic analysis, and then the clinical biological correlation are done in order to decide what to suggest to an individual, to a population, or to a patient by sharing decision-making and applying what is called the P5 medicine approach. In autoimmune diseases, as you can see here, we have a lot of data to collect, which can be put together in algorithms to make a prediction for a particular disease or a particular individual, in whom we can apply some preventive measures, personalize the attention, and allow the patient or the individual to participate in the transit from health to disease. There are several scientific opportunities of personalized medicine, even though in the practice we still not have good biomarkers to predict or to anticipate the outcomes of disease. And among these scientific opportunities, discover new biomarkers for prediction is a tentative and task. Discover determinants of individual variation in response to therapeutics, determine quantitative risk estimates in the population by integrating environmental exposure, genetic factors, and gene-environmental interaction. Also, personalized medicine would allow us to define a new taxonomy of disease and the relationship among diseases. Personalized medicine will also enable target clinical trials of subjects with rich clinical data, and making big data available to investigators will be very useful for the future of preventive medicine, for sure. So now let's show you a little example of what happened in a particular autoimmune disease, such as rheumatoid arthritis. We know that there are a clear genetic predisposition to this condition. In particular, DRB1, 04, and TNF2 polymorphisms are the strongest genetic risk factors for this condition around the world and also in Latin America. The PTPN22 polymorphism is also related with rheumatoid arthritis, not only to other autoimmune diseases, but in particular to rheumatoid arthritis. We know that the progression of the disease is very heterogeneous among patients. There are not two identical patients with the rheumatoid arthritis. As you can see here, an analysis of the radiographic progression of a cohort of patients with rheumatoid arthritis. There are a lot of heterogeneity among these patients. So we also know that familial disease, the HLA, and the presence of anti-CCP antibodies together are predictors of a worse prognosis of these conditions. So in an algorithm, we can include for the prediction of this disease and prediction of its outcome, these predictive factors. The genetics one, including DRB104, TNF2, and PTPN22. Two questions related to the tobacco smoking and the presence of familial autoimmunity, and one serological marker, which is the presence of anti-CCP antibodies. Altogether, these 6 factors allow a calculation of relative risks of 80, which is very, very high. So with these algorithms, we consider that for the future, in a longitudinal and prospective study, we can confirm whether or not these factors are really predictive for this condition and its severity. Lastly, some consideration for implementing personalized medicine. First is the cost. Even though For instance, the genetic analysis is cheaper than it was in the past. 23 medicine cost almost $70 per genotype, including 1,500,000 polymorphisms. So it's not really very. I mean, it's cheap. The availability of biotechnology resources. We have to have a good infrastructure, a biobank, laboratory omics tests, data storage and acquisition, bioinformatics and statistical tools. Third, population-based data. We know that most of the studies have been done in Caucasian population, so we have to replicate and adapt all the data to their own population. Not all the physicians are aware about personalized medicine, so education of healthcare workers is a consideration to implement personalized medicine. The specificity of the biomarker or the algorithm should be high, as I told before. One important concern is the confidentiality and data security, as well as the healthcare system regulation. Who will pay for personalized medicine? And the consequence is the insurance companies, how they will deal with this personalized medicine. Do I have to pay more if I have a genetic risk factor for any condition, or do I have to pay less if I don't have these risk factors? It's not an answered question yet. Also, the ethical issues concerning racial and ethnic disparity is important, and also how the society is informed and how the society will deal with personalized medicine is also a very important consideration. So, to conclude, once again, I think that personalized medicine is to practice medicine as it once used to be in the past, using the current biotechnological data. So I think that we have to be prepared for this new way to practice medicine in a real-life condition. And I like to finish sharing with you this sentence from Caleb Parry, who said that it's much more important to know what kind of patient has a disease than to know what kind of disease a patient has. Thank you very much for your attention.